Thank you very much for the introduction. So how do I move forward? So if asked for subjective comparison of these two coronary MRAs, I think most of us can agree they have pretty comparable image quality. But I think some of us will be surprised to find out that the first one is actually acquired exactly 20 years ago. I'm not saying we didn't make progress in the 20 years. Don't get me wrong. We actually made a lot of progress in terms of reducing scan time, improving the success rate, et cetera. But our competitors are doing the same too. So in terms of coronary CTA, I think compared to MRA, it still has huge advantage in terms of scan time and spatial resolution. So I think that's part of the reason we didn't have a debate session for this coronary MRA like yesterday for the peripheral parts. So we really have to up our game. So as Dr. Bonner mentioned earlier, so we were clear about a lot of the pros and cons about coronary MRA. I think, in my opinion, there's still major roadblocks that remains. For example, the scan time is still long. They are in minutes, not seconds, like we want them to be. The image quality is still variable. And although there are a lot of new techniques that's coming out, I think there's some fragmentation, also accessibility issue. I think was alluded by previous questions. Can you actually do it on different scanners and vendors? So in this work, we're trying to explore a new revenue for additional acceleration by doing super resolution. So natural image super resolution is actually a classical problem in computer vision. And with the renaissance of convolutional neural network, actually, there's a lot of improvement in the performance in the recent years. So if we think outside the box, if we can acquire a low-resolution coronary MR angiography and then use a super-resolution process to upscale the images to be a normal, typical coronary MRA at the current required resolution, like 1 by 1 by 1 millimeter, that would be tremendous. That will bring us multiple benefits, including the shorter scan time, and also possibility of even fitting into a breath hold, which will make the setup very simple and less variable. The larger voxels can also bring much higher SNR, and most importantly, this approach will be primarily a post-processing method where it can be compatible with existing scanners and sequences. So we implement a 3D densely connected super resolution network based on convolutional neural network. This kind of setup is useful for us to be able to fit into a 3D patches where we can utilize the continuity of anatomical structures in the 3D coronary MRA data set. And it has a lot of skipped connections, which will help reduce the number of parameters in for training, and also make it faster for training and less prone to overfitting. So we also try to improve the size of the data by performing a cross-domain MRA data training by combining both the coronary MRA and also public data with brain MRA. The brain MRA doesn't have any motion mostly, and also the vessels have similar size. So by boosting the data size, this can largely avoid the overfitting in the training. So this is the experimental design. We have the originally acquired coronary MR angiography, and we perform a case-based downsampling with 16 times in both phase encoding directions to generate a so-called low-resolution MR angiography, which will be interpreted to the original resolution And the further will be performed by a super-resolution reconstruction, which will generate a super-resolution MRA at the same resolution. So these three will be compared against each other. And since these patients are scheduled to undergo invasive angiography, you can use that as a ground truth. So the coronary MR protocol are pretty standard, contrast-enhanced, the 3T protocol. And we use a slow infusion injection scheme. The scan time is around 6 minutes on average. So in the data training design, we again truncated the outer case-based data in each of the phase encoding directions. And without going too much details, the training was finished within a few days, and all the training was performed on the GPU. So we evaluated the vessel sharpness, comparing the simple interpolation versus the super resolution and also the original MRA, and we can clearly see a significant improvement in vessel sharpness. We use the descending aorta as a consistent anatomical target for the comparison. And we actually see a huge improvement in vessel sharpness, and there was no significant difference between the super resolution results and the original coronary MRA. So we are very encouraged by that. We further evaluated the image quality, comparing the interpolated results versus the super resolution results, and we've seen significant improvements in all metrics, including the room mean square error, the peak SMRA, and also structural similarity comparison to the original coronary MRA. And we also compare those numbers in training with only the coronary data or training only on the brain data or in the joint training, and we have seen the best performance with the joint training. So some are patient cases examples. In this case, we are looking at a 73 years old female. We can clearly see a high-grade stenosis of the proximal LAD segment and minimal stenosis at the left main, which is validated well with the original coronary MRA, showing the similar findings with minimal stenosis on the left main and high grade on the proximal LAD. So in the low resolution and interpolated results, the images are very blurred to make any judgment for the LAD lesion, and we actually have an impression of a high-grade stenosis at the left main, which is a false positive, if you call it. So the super-resolution results improve the visualization of the anatomy much better and match well with the gold standard in this case. Another case, in this X-ray angiography, we've seen two high-grade stenosis in the proximal LAD section, which is also pinpointed on the original coronary MRA. However, on the interpolated, the low-resolution input MRA, it's very blurred to actually call these lesions. But the super-resolution results actually show similar results to the original one. One more case, in this patient, 73 years old female, we can actually observe a diffuse disease in the proximal LAD lesion with one particular high-grade stenosis. And this was observed also on the original MR angiography. The low resolution input images are quite blurred But I think we can still see some diffuse disease, but I think it's difficult to call the extent of the stenosis. The super-resolution results actually are much sharper and helps with the visualization of the stenosis. So we performed a blinded diagnostic reading of the in the testing set of 41 subjects with 12 segmental analysis with a range of stenosis, and then also for cases where there's no visualization, we also label these. So we de-identified all the data from 3 sets and also randomized the order. So this is the confusion matrix where we're comparing the reading from the high resolution original MRA to the low resolution reading and also the super resolution reading. I think there are some notable findings where we can see the top diagonal component are much higher with the super resolution comparison, which basically means the super resolution reading are closer to the original resolution coronary MRA for ruling out for calling no disease. And also, there are significantly higher number of segments that are deemed non-diagnostic with the low resolution data, where the number for super resolution data are much lower. So we have tested a retrospective downsampling data of coronary MR angiography with 4 times reduction in both of the phase encoding directions, which is the equivalent of almost 11 times acceleration considering the initial interpolation. Assuming we can acquire 28 lines per heartbeat, such acceleration factor will reduce the total scan to be 18 heartbeats, which can be fit nicely into our breath hold. So the proposed technique actually demonstrated the potential to improve the image quality of undersampled data and also the vessel sharpness. And this technique appeared to restore the anatomical details. We also have observed in the blinded reading that improved diagnostic performance was achieved with the super resolution. And also, we think the perceived improvements currently warrant further validation with the prospective low resolution scan and also a systematic evaluation by comparing to the invasive angiography. With that, I would like to thank my colleagues at Cedars-Sinai and also our collaborators in Korea and in China. Thank you very much.